Welcome. My name is Meredith Malnick, and I am Executive Health and Science Editor at HuffPost, and I'm today's moderator. We're here today to talk about the diabetes epidemic, and specifically the latest in treatment and prevention. And I want to start by introducing our all-star panelists, starting with my immediate right. LaShawn McKeever is the Senior Vice President, Government Affairs and Advocacy at the American Diabetes Association. Sarah Bleich is a Professor of Public Health Policy at the Harvard T.H. Chan School of Public Health. Elizabeth Halpern is Clinical Director of Adult Diabetes and a member of the Joslin Latino Diabetes Initiative. And Howard Wolpert is Vice President for Medical Innovation at the Lilly Innovation Center. And I also just want to mention that the event today is presented jointly with HuffPost and is part of the Dr. Lawrence H. and Roberta Cohn Forums. And welcome to Roberta Cohn today. We're pleased to have the whole Cohn family with us. We're streaming live on the websites of the forum and HuffPost. And we're also streaming on Facebook. This forum will include a brief Q&A, and you can email questions to theforum@hsph.harvard.edu. And you can also participate in a live chat that's happening right now on the forum site. So just to start, today is World Diabetes Day, and it's actually, I just learned, American Diabetes Month as well. And so I think it's a really appropriate time for us to talk about the ongoing scope of the diabetes epidemic in this country, and the disproportionate impact that it has in some of our communities, and some of the newest approaches and technologies and ways that we can overcome some of the problems and roadblocks that we still face. So I just wanted a word about our focus. Obviously, diabetes is a massive topic, and so we're really going to be talking about type 2 diabetes. And as you know, diabetes is a group of metabolic disorders that includes type 1, type 2, and gestational. And I think we'll touch on some topics that affect all types of diabetes, but really our focus is going to be type 2 today. I think we're going to address some of the misconceptions that exist in society, a lot of the ideas around to what extent illness relates to personal responsibility, and some of the ways that we're not addressing the systemic issues that really face people who struggle with these challenges. So, to start, we're going to actually watch a video clip. It is a video clip from the American Diabetes Association. They were kind enough to share with us. And we're going to hear from someone who's living with diabetes and some of the challenges that she faces as a result.
We used to travel to Beaufort, South Carolina, where our grandmother lived. One year I would go down, and I know she would be having some troubles with circulations, and so I'll go down still another summer. Maybe she's had a toe amputated, a leg amputated, and that went on for some time until she actually passed away. Diabetes is a progressive disease. It wasn't just my grandmother, it was my aunt, it was my uncle, it was my cousin. I just never thought it would get to me. And so when it did, I was shocked. I knew that people had these misconceptions about type 2s. I didn't want to share with anybody that I had diabetes at all. It was a huge hurdle for me. I remember hiding insulin in refrigerators. I just felt shame. That is, in fact, how I started volunteering with the American Diabetes Association as a way for me to cope. Maya Angelou said it best, when we know better, we do better. I'm a SNAP Ed program assistant, so that's what I do every day. I go out into the community and share nutrition education messages, if you will. Nutrition plays a major role in diabetes. I always use myself as an example, which is a huge accomplishment over the years, because I went from hiding insulin in the closet, not sharing my story with anyone, to using my story, if I need to help show that, hey, you can do it.
So LaShawn, I want to start with you. I was hoping that you could sort of give us a lay of the land, so to speak, and talk through where we are really as a culture and facing this disease, and how many people are facing it, and the whole landscape.
Sure. One, I'm really excited to be here today. As she said, today is World Diabetes Day. This is American Diabetes Month. And really our focus during this month is to talk about the seriousness of diabetes, to try and combat the stigma surrounding diabetes, and to really help people understand just the magnitude of this disease and why it's important for us to act. So I think the first thing I want to share is the scope of the disease. Nearly 50% of Americans have diabetes or pre-diabetes. And so that's 1 in 3 Americans are at risk for developing diabetes. Diabetes affects 30.3 million children and adults in the US today, and that's 1 in 11 Americans. One thing that we find is that no one really believes they're the one. And so there's a huge issue with people who are at risk for developing diabetes. There are 84.1 million Americans who have diabetes and are at risk for developing type 2 diabetes. And nearly 90% of American adults with prediabetes don't know that they have it. So those are just some of the numbers in terms of the scope of the disease. But why is this really important? Well, it's important because diabetes is a costly disease. If the complications go untreated, it leads to significant challenges for people living with the disease, and also it has a great economic cost. So it is the 7th leading cause of death in the United States, and it causes more death than AIDS and breast cancer combined. In addition, I talked about the complications. So blindness is an important complication that it causes, heart disease, stroke, kidney failure, and amputations. In understanding the economic burden of diabetes and prediabetes, it costs $322 billion each year in terms of healthcare related costs. And those is 2.3 times higher than someone else with diabetes. So it's a very costly disease. It carries a great burden for people who live with the disease. And today we're talking about, or part of what we're discussing is World Diabetes Day globally. According to data from the World Health Organization in 2015, 422 million people worldwide are living with diabetes today. So this is a huge issue as it relates from a public health perspective. And I think it's important for the folks that are gathered here today to talk about some of the solutions and how do we move forward from here. 2 other things I wanted to note is that, when you think about the problems related to diabetes, the issues that a lot of disproportionately impacted populations face, are a strong contributor to some of the issues that we're seeing in terms of the inequity in access to health care. And so that's just one thing I just wanted to note. We're going to talk a little bit about that later. But then also the part that I think is important is to talk about the stigma. So Michelle in her video, she talked a little bit about that, how she had to hide her insulin in the refrigerator and she didn't want people to know that she had diabetes. That's something that we hear about from the diabetes community a significant portion of the time. People are afraid that they are at risk of developing diabetes, so they won't go and find out if they're at risk or to understand their current health status. It causes shame. People feel that they caused it themselves. And so, again, it interferes with the treatment and management of the disease for a person with diabetes. And it leads to a lot of misinformation regarding what diabetes really is. And so it is a multifactorial disease. So it's a combination of genetic factors, lifestyle factors. There's a lot of things that contribute to it. And some of those things a person can control, but there are other things like your genetic makeup that you can't control that puts one at risk for diabetes. So, I think this is an important panel for us to have today. We certainly at the American Diabetes Association, this is something that, diabetes is a part of our fabric. And so I'm really interested to hear what the other panelists have to say, but I wanted to provide a sort of the scope of the disease.
Yeah, that's so helpful and so interesting to really see it's something that affects all of us, basically, someone we know or ourselves. So you mentioned that it's multifactorial and that one of the factors is behavioral and the food we eat. And so Sarah, I wanted to go to you and to hear a little bit more about some of the challenges and also some of the successes with sort of food policy and how addressing the food environment can affect health.
Thanks, Meredith. So as you heard Michelle say at the outset, Diet is a huge driver of the diabetes epidemic, and this is important because a person's ability to control their diabetes is very dependent on their ability to select foods or be in an environment which allows them to control their blood sugar. And it's also the case that the single biggest driver of the diabetes epidemic is being overweight or obesity. So food policies become really important because those are a way to modify what people eat and potentially both affect their diabetes and their obesity. And there are all sorts of food policies at the local level, at the state level, at the federal level. But the two that I want to talk about today are sugary beverage taxes and federal menu labeling. And sugary beverage taxes are a really important example because those beverages are the single largest source of added sugar in the diets of American adults and American children. And consuming those drinks is very tightly linked to both obesity and type 2 diabetes. And so across the United States right now, there are 7 localities which have passed sugary beverage taxes. Those range from 1 cent per ounce up to 1.75 cents per ounce in Seattle, which most recently passed a tax. And to put that in context, if you take Philadelphia, which has a 1.5 cent per ounce tax, what that's equivalent to is taking a 2-liter bottle, which costs $1.79, adding about $1 to it or increasing the price by 61%. So there are big increases that consumers are experiencing when these taxes go into effect. And there's not a lot of real world data right now in the US because these taxes are relatively new. What the data from Berkeley shows is that in the first year post-tax, sales of the drinks that were taxed, so sugary beverages, dropped by 10%. In our preliminary analyses of the Philadelphia beverage tax evaluation, which are not yet published, but we've just finished the 6-month evaluation, we're seeing a 57% drop in volume sales of sugary beverages. And because low-income populations are more likely to drink these beverages, the potential population health effects are really important when we think about diabetes and obesity. And if you turn to menu labeling is the idea that if you go into a restaurant or a large food retailer, calories are posted alongside price. And so this first happened in New York City in 2006 and then sort of disseminated around the country to 20 or 30 other locations. And it's a great example of how local policy percolates up to the federal level. Because in 2010, as part of the Affordable Care Act, they actually passed federal menu labeling, which was strongly endorsed by then First Lady Michelle Obama's Let's Move campaign. And so it is the current state is that the law has not yet been implemented. It's going to be implemented in May of 2018. But even in the absence of the law actually going into effect, there's been a lot of research which has asked the question, does it actually have an effect on consumers and does it have an effect on restaurants? And what the research shows is that the biggest impact from menu labeling is probably not because consumers like us or anyone make different choices when they walk into restaurants and they see calories posted. The biggest impact is probably because restaurants are reformulating their menus to offer lower calorie products. And so in work that we've done looking at the largest chain restaurants in the country, what we've seen is that restaurants are both taking the highest calorie items off of their menus and they're also reducing the calories in newly introduced items that are constantly coming on menus by about 60 calories or 12%. Now it sounds small, but at a population level, if you can extract that number of calories out of the diet, it can actually have a pretty big impact on levels of both obesity risk and diabetes risk. And the last point that I want to make is that there is a little bit of hope. And so I mentioned that sugary beverages are a really important target because they're such a key source of added sugar. We have a paper that came out today that looks at trends in sugary beverages from 2003 up to the most recent data in 2014. And what we find is that over that period, among kids and adults across all age groups, we're actually seeing declines in sugary beverage consumption, which is great. Now, the downside is that the highest levels of consumption are still amongst Blacks, Mexican Americans, other Hispanic groups, adolescents, and young adults who are also at highest risk for type 2 diabetes. So there's a need to think about, among the groups who are still at highest risk, how can policies be targeted to most effectively impact them?
Great. And so, obviously from a policy level, trying to address everyone at once, that's the goal, but I wonder if Liz could tell us a little bit about how you interact with individual patients and how how you sort of work with them to make the food choices on the individual level.
So thanks, Meredith. At the Joslin Diabetes Center, we're unique in that we're uniquely concentrating on diabetes and only diabetes. So that gives us a lot of time to spend with patients, more than a primary care doctor has, for instance. So a colleague of mine said to me yesterday, actually, you know, anyone can have diabetes, which means anyone. So someone who's very, with a high education level, someone who can read, someone who understands numbers, someone who cannot read, someone with no common sense, someone with, ability to take care of themselves. So we have to reach people where they are at any particular time. That may follow a continuum, but we need to understand people's needs at any time. A lot of what we do is goal setting so that people can manage their own diabetes, and my goals may be completely different from the person with diabetes goals. For instance, I know that lowering your blood sugar will, in the long run, decrease your possibility of complications of diabetes, but the patient's goals may not be to lower their blood sugars as such, but rather to be able to go to work every day, or have enough energy to play with their kids, or just feel well enough to be happy. So we have to, with the larger picture of knowing that I would like every person not to have elevated blood sugars and not to have complications of diabetes, we need to understand where everyone is. There is a lot of emotional baggage that comes along with the diagnosis of diabetes. As the woman in the clip was saying, she has shame and guilt, and there's a lot of vocabulary used when people talk about diabetes of good food, good carbs, bad carbs, behavior, good behavior, bad behavior. And, you know, we try to stay away from anyone feeling guilty about anything that they do. There's a reason for our actions, and we want to educate people so that they can make good choices for themselves. To that end, a team approach is very important with nurses, nutritionists, exercise people to help people influence all aspects of their life to take care of their diabetes. Depression, as we know, is intimately linked with depression. If the blood sugars are elevated, then it makes depression much harder to treat, and vice versa, actually. So we spend a lot of time on emotional issues and helping people figure out how to take care of them. And as LaShawn was saying, there's a huge disparity in the care to patients, and so we need to address the issues related specifically to people who are underinsured, and help everyone where they are to be able to access care and the supplies they need to be able to take care of themselves.
So continuing our macro to micro trend, Howard, I'm hoping that you can talk to us a little bit about some of the technological developments and the actual developments in medication and delivery devices, and how that landscape has been shifting over the past few years.
So we're actually reaching a junction now with technology, and particularly with communication and smartphones and cloud computing, where a lot of the issues and challenges that people with diabetes face, both individually and also at the population level intervention, can be addressed with technology. Some of the barriers and issues one faces really is the fact that there aren't enough endocrinologists or diabetes educators to meet the needs of people with diabetes. So there's a problem with unequal access. A broader issue really in terms of the current care model is the fact that people with diabetes really need 24/7 connectivity, because the condition where if a person gets into a period of metabolic instability, the glucoses go high or low. With the current care model, there's not an opportunity to access expert guidance, and so people end up in the emergency room or hospitalized. I think there's sort of a broader challenge and need here, and I think Liz sort of mentioned this, and there's really sort of a disconnect between the needs of people with diabetes and the actual care model. So the current care model is very sort of prescriptive. The patient is told what dose they should take, what they should eat, which is not only patronizing, but it's actually really effective in practice. And I think if I reflect on my career as a clinician, as a diabetologist, it's more been as sort of as a coach. So I think that the key in terms of intervening at an individual level is to provide people guidance so that they can make informed choices around how they need to adjust their insulin, let's say around different foods or activity, or rather than just simply prescribing a diet, is to kind of give them some insight of the impact of their different food choices on their glucoses. So I think the opportunity we have now with smartphones and with the types of connected devices, so for example, connected pens, which people use to deliver their insulin, but also we'll send that insulin data up into the cloud for remote analytics, is to essentially develop an entire cloud-based diabetes care system, which obviously would make expert guidance accessible to a lot more people living with this condition.
So a lot of problems, but it sounds like a hopeful message from all of you that there are sort of insights into how we can do better. And so I want to actually introduce our second clip from the American Diabetes Association, which really looks at some of the success that they found in treating patients.
I was diagnosed in my late 30s. My blood sugars were fluctuating. I used to say I can go from 400 to 40 in less than 40 minutes. I was testing my blood sugar once an hour and giving myself 8 shots a day to try and keep it in balance. I couldn't live like that. And so I needed a continuous glucose monitor. It warns me when I'm low, it can make adjustments. October 20th at 4 o'clock in the morning, I woke up and I thought my blood sugar's a little low. And I reached out to get the packet of sugar, and that's the last thing I remember. I have a sensor. It reads my blood glucose and transmits to my husband's phone. He was in St. Louis, and he got an alarm. And he tried to call me. He tried my cell phone. He tried the house phone. My neighbor finally got in. I was lying in bed with my eyes rolled back. I was ice cold. Without that technology, without the research that NIH and ADA and other organizations do, my husband would have come home from St. Louis and he would have found me dead in bed. And so I just can't tell you how much all of this means to me.
So Howard, I was hoping that you could put that clip into context for us. It seems to sort of jibe with some of your work that you're doing. You know, when did this technology sort of become available? How pervasive is it? Is it sort of universally available in the country?
So what she's referring to in that clip is a continuous glucose monitor. So this is a device which involves a sort of a transcutaneous sensor. So this is a probe that sits under the skin and measures the glucose continuously, and really has sort of transformed diabetes management in the past 10 years, because obviously diabetes is a condition where the glucoses will fluctuate markedly, and it's very challenging with current tools, even with insulin pumps, for people to regulate their glucoses and keep it in range. And what continuous glucose monitoring provides, and it is, as she relates, is data that can be linked into alerts and alarms. So she was describing their remote monitoring system that her husband has. I mean, the opportunity here with this type of technology on a population-wide basis is to actually set up systems where everyone with diabetes could essentially be monitored in real time. We also have devices that can actually measure people's insulin delivery. So the opportunity really is not only in terms of actually being able to provide a surveillance system for people in emergency situations like this, but with remote monitoring, collecting the data, providing people with guidance based on analysis of their glucose trends and their insulin delivery and how they can optimize their control. There's an opportunity now really to sort of scale up and provide care and optimize people's self-management on a wide scale. Where things stand in terms of the technology access at the moment is it's covered for most people with type 1 diabetes, but as the technology has improved, the price point has actually dropped, and so there is an opportunity now for people with type 2 diabetes with newer types of continuous monitors to have access to these kinds of tools.
So actually, I want to go back to LaShawn, something you said earlier about some of the stigma and shame keeping people from seeking that care, because I think obviously the advances in technology are only as good as the access that people have. And so if people are avoiding treatment because of a sense of shame, I'm wondering if you could sort of expand on that and tell us what you find, what you see in the field, and actually for any of you, if you want to touch on that topic.
So I think as it relates to stigma, when I initially commented on it, I talked about more how it impacts a person with diabetes. So as I said, people are fearful to disclose that they have diabetes. It impacts their willingness or just their ability to engage with their healthcare professional in a meaningful way. But I think the other side of stigma has to do with the people that are helping to drive that. So, where we see it, as we said earlier, I oversee our government affairs and advocacy work at the association. And we have to educate policymakers constantly about what diabetes is and how it impacts a person and why we need federal resources to increase research as it relates to diabetes management and treatment and all of the the tools and devices, why it's important to cover programs like the National Diabetes Prevention Program, which is a population-based, community-level prevention program that focuses on lifestyle interventions. So, I see it play out in that arena, and that the misinformation part is widespread, and we have this great technology. As he said, the continuous glucose monitor is an important part of one's management with diabetes. However, getting federal programs to cover it is a challenge. So CMS currently covers a type of CGM. However, there are still issues around it. Hillary mentioned the intersection with the device in her phone, and that's something that under this new policy, there are challenges around that. And so stigma plays a role not only just for the person with diabetes, but I think in the policy environment for policymakers who are making these important decisions about how resources are allotted for diabetes.
Do the rest of you find yourself educating stakeholders about how serious diabetes is and to what extent it needs to be taken seriously in a policy or research context?
From where I sit, so hearing from both Hillary and Michelle, one of the themes that's coming across is once you have diabetes, it is such a hard disease to manage and to have treated because it just is so hard for an individual to deal with on their own. And so from where I sit, where I really try to push policymakers is how do you keep someone from getting in that position? How do you prevent the onset of diabetes? And that's where population-based policies, the DPP program that LaShawn mentioned, become these really important vehicles. And that is for both diabetes and obesity, because these are long-term chronic conditions for which there is not great infrastructure for all people that need it to have the right tools available to them to reverse these conditions. So from a public health perspective, what we really want to do is try to stop the diseases from ever touching people in the first place.
On an individual level, if a patient feels shame about the diagnosis of diabetes, they will likely not share it. I have patients who don't share it with their family or with their coworkers, which means, if, for instance, if they have a low blood glucose level while they're at work, it may not be recognized by their coworkers because they didn't know they had diabetes. And additionally, if, like the first clip, the woman whose grandmother and mother and all her family had diabetes, for her, the diagnosis of diabetes means she's going to lose a foot, right? So there's ways to prevent that, of course, if you keep your diabetes under control, but she's probably just so fearful about the complications of diabetes that may paralyze her in terms of her own self-treatment. And in that way as well, when we try to use insulin, which is a very effective medication, people have a lot of preconceived fears about it, and it's a medication that works very well that happens to be an injection, and so it's hard to get people to move forward. It's hard actually to get primary care doctors as well to start their patients on insulin because of that sort of wall between oral agents and insulin. It feels like a huge drop off a cliff.
Where do you think some of this fear and shame comes from? Like, what is the sort of foundational idea there? Why would it be shameful to have diabetes?
Well, I think people feel that it's their fault often. They feel like they've eaten themselves into diabetes, that they're that's the impression that everyone has. It's due to your diet and it's due to lack of exercise. And we do say that a lot, but it's nobody's fault. There's certainly a huge amount of factors which are both genetic and environmental. I have patients who don't want people to know they have diabetes because those people in their life will then comment on what they're eating, which, back off, right? So, that's, I think it's hugely packed with emotion, the diagnosis.
And that I'm sure makes some of the food policy work harder because there is that fine line, between, policing food. And then there is sort of an attitude, I think, among some people that the food policy recommendations are somehow starting to go into that territory. So how do you sort of navigate that in your recommendations? Like, how do you sort of respond to people who maybe feel like food policy choices can sound stigmatizing to some people?
Well, it's interesting because if you were to poll the public now, or you were to say, exactly to your point, do you feel like type 2 diabetes or even obesity is caused because of your individual behavior, because of your broader environment? The vast majority of Americans would say it's because of what you and you and you and you do. I think it's an individual level problem. What the scientific literature points to is that we are living in environments which strongly promote overconsumption of food and too little physical activity. And it's that constellation of factors which is driving the joint epidemics of obesity and diabetes. So where it becomes very tricky from a policy perspective is you're trying to get policymakers to do evidence-based policy which is supported by the scientific literature, but their constituents may not want that same type of policy to pass. So if we think about sugary beverage taxes, yes, there are 7 places around the country which have had success, but they are hugely contentious legal battles. And before they even get to that point, they're hugely contentious in the political arena. And so there are many instances where cities have tried and failed. In the case of Philly, which has a tax, it failed twice and then passed. And in a very high-profile upset recently, Cook County, Illinois, which would have been the largest jurisdiction to cover a sugary beverage tax, had it and it got repealed. So there's a lot of momentum moving along, but there are a lot of political challenges, in part because the constituents are pushing back hard, interest groups are pushing back hard, and the politicians are naturally responsive to the groups that they are beholden to.
So Howard, going back to what you said earlier about the health coaching aspect of some of the technology that you've been working on, I wonder if you could talk a little bit more about how that plays a role in sort of promoting good behavior and making that accessible and non-judgmental.
Well, just as being related, there's a lot of judgment and blame in the care process here, finger pointing to patients, which actually in practice leads a lot of people to disengage. And I think a key part as a clinician is actually acknowledging people's burden in terms of managing their diabetes. And that's actually a place where technology can actually help in terms of relieving a lot of the daily tasks. Someone had calculated the average person with diabetes is making 300 decisions around their self-management per day, in addition to everything else in life. So it's no surprise that a lot of people don't measure up to what would be ideal because of all the other challenges they have to face in life. And that's actually an area where technology can help in terms of providing guidance and taking a lot of the decision-making out of a person's hands so they can kind of get on with their daily activities.
And then further reducing costs in this arena, you mentioned that the continuous insulin monitoring and the prices has dropped. Are there other technologies that you think are more accessible to people due to cost?
Well, I think where there's an opportunity in terms of technology and the whole cost equation when it comes to diabetes care is really actually re-envisioning the whole model. So if you look at the way things are at the moment, the current guidelines are that people should go and see a healthcare provider every 3 months based on no data. The opportunity with remote monitoring is to risk stratify people based on their actual needs and the monitoring of their glucoses and their insulin dosing, so that you could come up with a model where there's some people who are on track, they may only need to be seen once a year. Other individuals may need to come in more frequently. I mean, what I frequently find in practice is with a lot of people who, just because of competing life demands, who sort of go off track with their diabetes, I'm seeing them 6 months later when I really should have had an opportunity to help intervene and guide them much sooner. So there's an opportunity with remote monitoring systems to structure the healthcare system so that there's much more cost-effective use of healthcare providers. I think the other area where there's huge expenses, and LaShawn had kind of mentioned this, relating to hospitalization with people with diabetes, with people who are admitted with severe hypoglycemia, for example, or during transitions of care when people leave hospital, there's a high risk if they have diabetes that they're going to be readmitted because as people recover from health, their metabolic needs may change. And the opportunity really with remote monitoring is to be able to not only to track those people, but to intervene and provide guidance remotely. And think of it for people, the patient as well. I mean, in some future state, instead of having to sort of take off time from work to come in to see a clinician, a lot of their care can be received at home or in the workplace on demand. So there are opportunities there really to sort of scale up in efficiency and reduce costs with technology.
I'm wondering if we can turn the conversation a little bit more towards disparities, and this is a question for all of you, but based on something Sarah said earlier about how some of the policies, you're really looking at how they focus specifically on the populations most affected and how those populations are sometimes most resistant to the policies. I'm just wondering if you could talk about sort of what you're finding in the field, like what kinds of disparities you're seeing, and what's being done to sort of address that stuff. Yeah.
So in obesity, there have been these persistent disparities for several decades where you have blacks having higher rates than whites, for example, and they have just really tracked along, and it's really hard to close those gaps. So the question becomes, can you use policy as a way to begin closing some of those gaps? And there has been some success in the case of sugary beverage taxes. So I mentioned Berkeley, the first place in the US to have a sugary beverage tax. They've done one study, one of several, where they've looked at, in low-income communities in Berkeley, at sugary beverage consumption. And what they found is that it looks like post-tax, there's about a 21% drop among low-income communities. And that makes sense because low-income people tend to be more price sensitive. We know they're higher consumers of sugary beverages. So it looks as if the policy is having its intended effect. Now, the holy grail question is, does that affect someone's diabetes or obesity? And that is an open question right now. In the case of menu labeling, what's interesting is on a given day, a third of adults and a third of kids are in a fast food restaurant. Those numbers are higher for low-income and minority adults. And so if it is the case, which we're seeing in our data, that large chain restaurants are dropping high-calorie items, that they're taking calories out of the newly introduced stuff, and people tend to be buying those items, then that can also have a big population and level impact of saying, I'm not going to change the way you eat, I'm not going to redirect you because human behavior is very resistant to change. We have all broken New Year's resolutions, I'm sure. But you're just sort of taking someone's environment, pulling some of the calories out, and in doing so, hopefully making them a little bit healthier. Importantly, it's not a conscious decision, so you don't feel like you're being deprived. And it's that moment of deprivation where people largely overcompensate, and that's what you don't want from a calorie perspective. So I do think that menu labeling and sugary beverage taxes have a lot of potential. The challenge is that these are complex diseases, and there is no one silver bullet solution. So what you need is a lot of things happening in concert at the individual level, among policymakers, from the academic science. And when all those things come together, they, as a symphony, can really start attenuating disparities in a meaningful way.
Does anyone else want to discuss disparities? Or?
So I'll talk a little bit about it. So, this is a huge problem. I mentioned earlier about the impact of the disease, and a lot of ethnic and racial minority communities are disproportionately impacted by diabetes. One example that I think is important to note, because this is an active issue that we're working on, relates to the American Indian and Alaska Native community. They have the highest rate of diagnosed diabetes at 15.9%. And so one of the things that we're advocating for on behalf of this community is what's called the Special Diabetes Program. The Special Diabetes Program is funding that goes towards programming for the American Indian Alaska Native community and also for type 1 research. And so this program has been a significant federal investment in programming, diabetes programs directed at these communities, and has demonstrated decrease in kidney disease, for example. So this is an important investment that's been made over many years, and that's one of these one of the things that are currently at risk. When I talked about how policymakers don't always understand the impact of policies and how their decisions matter. Like, this program has been in existence for a very long time, and now that funding is at risk, and so that's something that we're advocating on behalf of the American Indian Alaska Native community.
So that brings up another interesting point, which is just, cultural sensitivity in some of this programming, and making sure that people, it gets back to your point, Liz, of like meeting people where they are, and also just making sure that everything that's being recommended is sort of culturally appropriate. And I'm wondering what challenges you face there, and what are some of the programs like this, this program that LaShawn mentioned that might sort of help address some of those issues.
Yeah, so again, we do try to reach people where they are, and that, I can make many recommendations about a proper diet or exercise, but if someone's living in a neighborhood that has no grocery store close by, that's going to be not feasible. Or if there's no parks in the neighborhood, then they can't really do exercise. Or if they're fearful because it's for their safety, then they may not go out, and then they'll stay inside and become socially isolated as well as, sedentary. So you try to understand what someone's situation is before you recommend just things that would be up high in the sky. Education level, of course, is important, and maneuvering the insurance system is hard enough for anyone with a PhD, and for someone who either has a very low level education or doesn't read or doesn't speak English, it's nearly impossible. I don't even understand how it is possible. So in any way that we could help, we do have, for instance, where I work, we have programs specifically aimed at the Latino population and the Asian population, which is also a group that's at higher risk, and we're expanding those approaches. For instance, in the Hispanic population, losing weight may in fact be a sign of illness as opposed to health, right? So you don't just want to tell someone that they need to lose weight and be skinny, because that would make them feel unattractive. And so you need to understand every individual's understanding of the factors that are at risk here.
And I'm wondering, Howard, in terms of the technological innovation, how to what extent is cultural sensitivity and sort of approaches that are tailored to different communities a consideration in some of the work that you do?
I think it's obviously key in the sense that in terms of the work we do with human factors, and that technology has to be tailored to the end user and to their preferences and health literacy. I think where there's a broader opportunity, and actually, building off what LaShawn had kind of mentioned, and we're talking about the scope of the problem and highlighting it, but when you think of what the potential is and how far we've come, when I think professionally 30 years ago, at the Joslin, the number of patients we had there who were coming in with seeing eye dogs or, in wheelchairs because of amputations, and that's no longer the case, because we do have the tools to actually substantially impact on diabetes. I think the issue here really is in terms of scaling up access and expertise. And to LaShawn's point about, if you look at retinopathy, diabetic eye disease, which is the leading cause of blindness in the U.S., what people don't often mention in the same sentence, it's only less than 1% of people who have advanced retinopathy who actually end up blind. So if you can screen and identify disease early on, one can substantially intervene. And one of the innovations with technology in the last 10 years has been the introduction of remote telemonitoring, so that even in the reserves out in the Dakotas, people with diabetes can get access to expert eye screening, and early signs of eye disease can be identified and they can get intervention. So I think there really is an opportunity with the types of technologies that we have coming along to have a substantial impact in terms of affecting health disparities and providing expert guidance and care to everyone with diabetes.
To that end, there are programs, as Howard was saying earlier, that there aren't enough specialists in diabetes to take care of the entirety of the problem of diabetes, but and primary care doctors are the front line. And there are programs where one specialist will speak to a group of primary care doctors remotely, so in different parts of the world, and try either case discuss or pathophysiology discussions or various treatment options, so that the primary care doctors can have the tools to be able to take care of their whole population of people with diabetes.
So before we go to questions, I want to just, I was hoping that we could go around and just say one area of policy or innovation that you are really excited for in the coming year, something that you think is going to make a difference in the near term. So I thought we'd start with you, LaShawn.
So I know we talked about a lot of things that are not so great about diabetes and some of the challenges, but something that I'm really excited about has to do with the National Diabetes Prevention Program. So starting in 2018, Medicare will cover this program as a part of a benefit that it will offer for seniors. And this is a group that is at high risk for developing diabetes. This is something I'm extremely proud of because of the work that the ADA has done starting as far back as 2009, working to get the National Diabetes Program established along with other partners, and for the funding that then followed under the Affordable Care Act. So this is something that has great potential from a population base. It is a scalable community lifestyle intervention program, and I'm really excited to see that move forward in the year to come.
And I'm most excited about the potential for sugary beverage taxes to meaningfully impact several diseases related to diet, like diabetes and obesity. And I think big picture, food-related policies can really help with these food-related diseases, but it's important that they target environmental change that makes it just easier to make a healthy choice rather than individual change, which is very, very resistant and hard to modify over time.
I'm hoping that with the concept of accountable care organizations, that instead of sort of penalizing patients with diabetes and not paying sufficiently for what they need in the short run, seeing what would prevent hugely expensive things and complications and decrease in life expectancy in the long run, that we can better take care of patients by giving them everything they need up front and not treating their complications once they already have them.
At a risk of repeating myself, the opportunity with smartphones and cloud computing is to provide diabetes care at scale to everyone wherever they live.
Great. Well, thanks so much. And Lisa, I think, has some questions from online.
Why don't we take an audience question first?
I think obviously, physical activity, diet and body weight among the top predictors of type 2 diabetes and explain a large proportion of diabetes incidence. Although also apparently they are not the only risk factor. I just want to have the panelists' view regarding the role of certain environmental pollutants that are known as endocrine disruptor, obesogens, diabetogens, or whatever you want to call them in the etiology of type 2 diabetes. And comments regarding solutions are also appreciated. Thank you very much.
Any takers for that question? Environmental impacts?
I'm certainly no expert in endocrine disruptors, but I do believe that they play a part in the increased incidence of obesity and possibly diabetes, as well as who knows what other diseases. So I do believe policy should take that into account and limit the use of pesticides and additives into plastics and all. But again, I'm not an expert in this, but I don't, as a clinician, I don't know how I would account for it except to tell people to avoid certain certain products and wash their vegetables and fruit.
Okay, I think online is
Great,
back up
thank
and
you.
running.
I'm back up and running. This is a question from Pete Dupree. Hello, as a state TB program manager and TB controller, diabetes is the #1 comorbidity we find among our TB patients. I'm curious if anyone is looking at collaborating with diabetes educators and TB clinics on linking at-risk patients to appropriate providers. These are hard ones.
I am aware of initiatives in India where there's a very high prevalence of both TB and diabetes, and it's clearly been identified that they interact. I mean, TB, like any inflammatory condition causing insulin resistance and actually bringing on the diabetes, and then hypoglycemia impacting on polymorph and immune function. So there is work in India at the healthcare level in clinics integrating both TB and diabetes care, but I'm not aware of anything in the U.S. around that.
Thank you. That's very helpful to hear about that outside the U.S. I know we've talked a lot about health insurance, but we've had a couple questions come in about that, so I'll take this one. CGM is a wonderful tool for diabetics, but very expensive. Is there a program that would help cover part of the cost and make it less expensive?
As LaShawn was mentioning earlier on, CMS has recently decided to extend coverage for CGM for people with type 1 diabetes, although it's in a restricted way. I think what's going to happen, and we're already sort of seeing this with newer CGM technologies coming along, is as the adoption increases and the production volume is increased, the actual price point for the technology has actually dropped. So I think that's inevitably going to make the technology more widely accessible to some people with diabetes. But
so I just wanted to sort of add a broad perspective around health insurance. So every year we survey our diabetes advocates. We have nearly 500,000 now, and we send out a survey in July and we ask them what are things that are important to you that we should be focusing on from a legislative and regulatory perspective. I would say for the last 5 or 6 years, health insurance has been the #1 area of concern for people with diabetes because it impacts their access to providers, their access to the tools that they need to manage their diabetes, medications. So this is an area that is extremely important for the diabetes community. As you saw over the last couple of months, that the chronic disease community spoke out when there was an attempt to repeal the Affordable Care Act, because this provided a foundation for care for people that, if you so for example, I would share with people when I was trying to explain how people with diabetes are benefited from the Affordable Care Act, is that you have to go back to the time before there was the Affordable Care Act, when simply having diabetes, you could be denied coverage or you could be charged extremely high rates for your coverage. And so this area of health insurance and coverage for the tools and devices and technology that people with diabetes need is very important.
Thank you. I'll take one more because I know we're running out of time. This is from Emily Keenan. She's a health initiative educator at Virginia Early Childhood Foundation. Her question is, I'll just paraphrase, it's about the accuracy of considering obesity as a marker predictor of diabetes. Obesity in this frame may suggest poor diet and thus poor outcomes, but obesity itself is not the cause of health problems such as diabetes. If this is true, can you discuss what needs to happen to reshape this conversation, which is so often framed as shaming and personal responsibility issues, rather than a food landscape systems issue? So her question is about how to reframe it so that it isn't so focused on food and food shaming, or you were talking a little bit about that earlier.
It is the case that the vast majority of people that have type 2 diabetes are also overweight or obese. It's about 90%. It's also the case that if you have obesity and type 2 diabetes and you lose weight, you can often reverse the condition. But what's also true is that the reason people become obese is often not simply because they made bad choices, it's because they're surrounded by environments that are promoting those bad choices. So this gets back to the tension between what the public believes about these conditions versus what the science shows. And what the science shows that these are environmentally driven problems, largely. Individual behavior matters, but it is not the key mechanism. And so in terms of reframing, I think that's where it needs to go. How do we think about modifying the environment in meaningful ways to encourage healthy choices, which make it really easy to make a healthier choice?
Great, thank you. Thank you so much.
There were some more questions in the audience. Yeah.
I just had a question. I just had a question leading off of that point. In terms of food insecurity and the availability of healthy food, have we seen state or local governments propose successful initiatives to address that issue of food insecurity within the context of diabetes?
So the best way that we have federally of trying to grapple with the problem of food insecurity is through nutrition assistance programs. And so the Supplemental Nutrition Assistance Program, which covers about 44 million Americans, 1 in 2 are children, and it's got a price tag of about $76 billion per year, has been shown to both lift people out of poverty, which is really important, and also address both food insecurity and very low food insecurity. So that becomes really important for people that have diabetes. What some research has shown is that for those families that are on food stamp budgets, which is the former name for the SNAP program, is that when they get towards the end of the month, those budgets get depleted quickly. And for patients with hypertension, they're more likely to have hospital readmissions during that time because there simply aren't enough calories that they have in their diet. So at the federal level, that's what's happening, but I think that there's a lot more work to be done because if you take just looking at the SNAP program, it is meant to be supplemental. It's not meant to be holistic and help people comprehensively deal with food insecurity. So there's a lot more that needs to happen, and often the way that happens at the local level is through food banks and other places which are largely dependent on charitable donations. And so then you often have a supply side problem of getting the right foods in the right people's hands.
Great. I think that's all the time we have. So thank you so much to our panelists, and thank you for the great questions. And you can continue the conversation at the forum website, forumhsph.org. And please join us on December 5th for another conversation about the health data revolution. So protecting privacy and improving outcomes using healthcare data. So thanks.